Thank you very much. This is the subject. The reason this has come about is because there is a new contract in the offing for April 2017, which you'll all know about, and I'm sure you'll all be waiting to hear from Alan McDevitt telling us more about that. I'm just wondering if I could have a show of hands of how many people are GPs in Scotland? Vast majority. Excellent. Super. And really the reason why this is of interest to me is that I think we need to do things slightly differently. Governance is here to stay. There's no question about that. Whoops. Can't go back, can we? Yes, we can. These are the things we all know about, but the bit that I'm really interested in talking about tonight today is the last one about the GMS contract and how we make sure that the governance within that is appropriate and actually how we need it to be. At the moment, you've got the QoF, which you all know and love, and that's a bit of a screenshot from Vision. And a comment from the delightful Iona Heath. At the moment, we waste effort, money and time collecting data and pursuing quality targets so that we have less time to listen and risk losing sight of the suffering human subject. And we risk destroying quality in our attempt to measure it. I think she's right. And increasing numbers of our colleagues are saying the same. And actually, even more importantly, increasing numbers of patients are saying that. And actually, even more surprisingly, people like the GMC and other investigative bodies are beginning to say that too. We've got to take this seriously. This is partly because of the Goodhart's law, which I mentioned earlier. When a measure becomes a target, it ceases to be a good measure. Think of any of the measures that we've had, particularly to talk about things like some of the depression criteria, the use of the PHQ-9. I'm actually quite a fan of that, but that's another matter. But I was a fan in it at a time when I chose to use it in a particular way for particular patients. I'm quite aware of how the effect it can have on consultations. And I'm one of those doctors, hands up, who may well have read codes of something like stress at home rather than depression as a result to get around this. So we need to take this seriously. And actually, I've said before earlier, I don't think there's any evidence that it's actually improved the overall system's working. We know that it improves those things that you measure, but actually with the complex jobs that we're doing, there's no evidence that performance-related pay works. You tend to find that other things get missed. We spend so much of our time with our heads in the corner worrying about QoF, we forget to look at the rest of the room. So what do we mean by quality? That's the next thing I'm coming to, because I think that's not straightforward. What is it we mean by quality, and how can we broaden it to mean something a little bit more than just the empirical measure of evidence? One of the things that improved the quality of my practice is actually a redevelopment of the practice. It's taken us 18 years, and that picture was 4 years ago with the scaffolding, and the picture of me and some of my team was just earlier this year when we finally got in, and interestingly enough, we got commended for a building award for what's happened. Made a huge difference, but we can't forget the context that we're working in. We can't forget the people we employ, the premises we work in, and those who work around us, because we're not in isolation. And I said earlier, this big thing about interface is absolutely crucial. So it's not just about the staff and the premises, it's not just about the where, the context. It is about audit. I'm not going to shy away from audit. These are figures from a few years ago, but actually, I wonder how many of you have run along to find where your practice fits in there. And I see Highland doesn't do particularly well. Perhaps we've improved since then. But this is just an illustration of how data is important. And actually, if we are saying that we're going to provide good care to our diabetes, well, what's the evidence of that? It's absolutely right that we do audit. It's absolutely right that we're monitoring what we do, but it has to be as part of it, and that can't be thought of as quality in its own without looking at it a bit wider. The next is the not just what we do, but how we do it, competency. So in Scotland, we've got the Scottish Online Appraisal Resource. We plug into it each year how we've been keeping up to date, and no doubt we'll be reflecting on what we've learned today to pile that in. But certainly we all have a professional obligation to make sure our competencies are up to scratch. think it's been a big bonus about the MRCGP exam is competency based. It means that we've got doctors who've got the skills that we think are important to do that. And it has to be taken into that. But how do we incorporate that into some form of governance structure? How do we ensure that the patients are getting the care that we assert to be doing? Because I think that's important. Which comes down to the why. So why do we do this work? What are our values behind that? I do like the RCGP motto. It's cum scientia caritas, in my schoolboy Latin, something about science and caring. That seems to sum up a lot of what we're trying to do. We all take pride in knowing the facts, knowing the science, but we all take a particular pride in how we deliver that and how we're actually meeting the needs of our patients who are in front of us. And I think that's about values. So what about values? So what about if we could actually isolate what our professional values are and actually aspire to live up to those values? John Gillis's document, Essentials of General Practice, really did a good job of looking at that, looking at actually what is under the bonnet of general practice, to think about what we're... Anyone who hasn't read that, I recommend it to you just to get your head around some of these ideas. But actually a lot of out of that is not rocket science, and the 5 capabilities which provide the overriding headings for the MRCGP exam actually look pretty good to me. Knowing yourself and relating to others, well, we could all relate to those and all relate to some of the hard help values that we've got. So when we're actually working to our values, when we're being productive in that context, I believe that's the time when I find practice the most satisfying. Equally, when the work, with the way we've been set up to work, means that we're working in ways which actually are not congruent with our values, I find that deeply unpleasant, deeply demotivating, and actually the time when we really we make these compromises about how we're going to provide the care that we want to, but against actually the care that we're being measured on. And that's the challenge. So this is the vision. It's the idea of having peer-based and values-driven governance. I think we can't do this in practice in their own. I think there's too small a unit, and I think it become too insular. But why don't we get into locality clusters of GPs? Say between 20 and 50,000 patients, a reasonable size, but ensure that actually there's more than one practice involved. And actually meet to agree a public values statement. And public's important because we've got to have public accountability on this and community accountability to this if actually we're going to be seen to be the community doctors that general practice is so key to. Again, that's probably my value. Hopefully that's shared. But that may be something which we need the political guidance on. Then once we've got that value statement, what would we do about it? That's something which would be owned by that locality, and up to that locality to undertake the audits and the quality improvement to see that actually we're doing that. And we may well get some very uncomfortable conversations with some patient groups saying, you say that continuity is important with Dr. Mack, do you realise I have to wait 4 weeks to get your appointment, or do you realise it was 6 weeks now? Okay, well why don't we do a bit of quality improvement work to try and deal with that? So it's all about demonstrating congruence of practice with our values, and actually will rely on some quality peer reference data. So some of the data that we've seen in Spire, some of the data that we've already been producing in QoF will probably need to continue. I'm sure we're going to need to continue to be recoding and actually recording data, but that's the way it's going to have to be. I also think these clusters actually will be quite useful in other ways as well. We're all going to be part of integrated joint boards, apart from the Highlands, when we've got a different model. How GPs are going to link into that is a really troubled question. And believe me, I've been to quite a lot of integration meetings in the last few months, as you can imagine. And some of them have been quite uncomfortable actually saying, well, what's general practice going to come in? And actually quite uncomfortable to answer that, because I'm not quite sure what our role is to be involved in that. when at the moment so much of it is about structural change and changing the contractual ways between the rest of the NHS and local government, etc. But actually integration, if it's going to mean anything, is going to have to be about us being integrated with that team, integrated with primary and secondary care, and also integration between the rest of us and the third sector. But GPs in a cluster, probably we can make some difference in those sort of interface discussions that actually would be unrealistic for single-handed or small practices to do on their own. I think a great opportunity to improve the interfaces with the NHS, and we hope that we can build on that with our interface work stream that the Royal College of GPs in Scotland is pushing forward. I also think it's going to be an opportunity to build leadership and quality improvement, capacity within general practice. I find it really difficult to think about that we're all being challenged to be medical leaders and learn the skills for that. But actually, without context, that means a bit hollow. But actually, if it's to be a leader of something, actually to do something, then that leadership will mean so much more. It will need supported, and it will need that quality improvements knowledge too. It's a huge amount of work going on with SPSP and other things, that we shouldn't just be consumers of an end product in a small digital space, but we should actually understand quality improvement and actually use that. And those three things we were talking about, autonomy, purpose, and mastery, we need to grasp those, that we're actually doing quality improvement on those terms. And that's the way we'll have the personal motivation to do that and to continue to do that and to do it in a meaningful way to support the practice we're doing. Hopefully it'll be a focus for educational activity. Hopefully it's going to start to share some of the ideas we've heard about IT and things like that, just best practice. And I think we can't just be too insular in practice anymore. It's awfully easy to be in our bunkers, and actually it's going to become ever increasingly tempting to do that if the rest of the NHS ignores us. But it is also about the community accountability. It may also about service planning and developments that actually the locality clusters will give us an opportunity and a voice to do that in a meaningful way. And most of all, a bit about providing some enabling environments. That's jargon, I know, but it seems to make sense. Some sort of environment where it's okay to experiment with new ways of working and develop new models, which are really appropriate to the care that we're producing. So actually, what's happening in Leith, this needs may well be very different from me in Dingwall, and very different again on the Isle of Mull. We need to have that flexibility and the ability to work across in these very different contexts. Most of all, I think it's an opportunity for general practice to take centre stage of the NHS. If this is going to happen, we really need some commitment to put general practice at the core, for us to be this hub of general practice and for it to be actually valued in that way. This is the only way that we're going to see 2020 vision work out into some meaningful way. We've had 2020 vision for quite a few years. I'm really not sure if I can find how that has clearly influenced practice as far as what the developments have been. I think that's going to be a really important thing, particularly as we come to renew that, which I know is being looked into for the next 5 years. So that's the model, that's the ideas. I've done it in 14 minutes, which I'm hoping that gives us 5 minutes to ask some questions. And I really want some questions, because this is one of the first times that we've had a chance to share this in a public audience. I know Jenny's at the back, who's been one of the executive officers for RCGP, who's been helping with this work, and I'm sure we'll be doing a lot more for that. Is this something we would value? Is this something that we could sell to the government? And is this actually going to give us the robust way of moving our practices forward and actually providing the sort of care which we're aspiring to for our patients? Thank you.